Good morning. Thank you for joining us for Winship Ground Rounds this morning. If you are an Emory University or healthcare employee and you would like to receive CME credit hour for attending, the access code for today's meeting is 155650, and it can also be found in the chat feature at the bottom of your screen for our virtual attendees. If you have any issues with this webinar or the CME login, please send Kadiatu Fofana an email or drop a note via the chat feature. This morning, it gives me a lot of pleasure to welcome Dr. Kimberly Curseen. Dr. Curseen completed her medical school training at Virginia Commonwealth University in 2000. She subsequently completed internal medicine residency training at Yale University and completed a fellowship training in geriatrics and palliative care at the University of Arkansas for Medical Sciences. Dr. Curseen is the Director of Supportive and Palliative Care Outpatient Services for Emory Healthcare and serves as the Director and the primary provider for the Supportive Oncology Clinic here at Winship Cancer Institute. Board certified in internal medicine, geriatrics, and palliative care. She is part of the clinical care team providing physical, emotional, and spiritual care for patients with cancer at any point in their disease process and assisting patients with complex decision-making. Before joining Emory, Dr. Curseen served as the program developer and the Director of Geriatric Palliative Care Clinical Services Program at the University of Arkansas. She has been named one of the palliative medicine inspirational leaders under 40 by the American Academy of Hospice and Palliative Medicine for 2014-2015. She has consistently been listed in the Atlanta Magazine annual Top Doctors issue since 2020. Please welcome Dr. Curseen today for our talk, Medical Cannabis, the Georgia Law and Beyond.
Hi, thank you for that warm welcome. And thank you for allowing me to talk with you today about a topic that I'm pretty passionate about. And I hope today to share information that will be practical and helpful. So unfortunately, I have no relevant financial disclosures. But I do want to start with a disclaimer. It is crucial to emphasize that medical cannabis is not and cannot be marketed as a cure or a treatment for any illness. So what I hope we're going to do today is understand the Georgia laws concerning medical cannabis, go through some of the literature, review the pharmacokinetics, and discuss some communication strategies. So I think it's always good to start with history to try to figure out how did we get here. So the evolution and regulation of cannabis in the U.S., in 1937, it was legal. It was actually listed in the Pharmacopoeia. The American Medical Association didn't like that at all, but it was right there along with cocaine. However, there was a movie called Reefer Madness that came out not to really address difficulties or fears about medical cannabis, but really to address racial mixing. But the unintended consequence of that movie made the population and the government afraid of marijuana, and that's how we shifted towards opiates for management of pain. So medical cannabis is now classified as a Schedule I drug by the USDA. So high potential for abuse, no accepted medical use in the US, lack of safety use under medical supervision, cannot legally be prescribed under federal law. But some synthetic cannabinoids are not classified as Schedule I. So the ones that are legal, the ones that are made by Big Pharma, you may be familiar with, is Epidiolex, which is a CBD treatment for children with seizures. It's actually made from the cannabis plant. Dronabinol, which is Schedule III, It's designed off the structure of THC, and it has indications for nausea and vomiting, for chemotherapy, induced nausea, vomiting, and then anorexia and weight loss in patients with AIDS. Nabilone, a Schedule II synthetic cannabinoid, also mimics THC, and it's approved for nausea and vomiting secondary to chemotherapy. And nabiximols is whole plant extract of marijuana that contains THC and CBD as a one-to-one. It's available only through clinical trials. It's not available in the US, but it's primarily used for spasticity secondary to MS and for chronic pain. So as you know, that medical cannabis continues to remain federally illegal, but the states are starting to legalize it. And often people come to me and say, well, why are we where we are? And who actually is in charge of this? So the National Institute on Drug Abuse, or NIDA, oversees the cultivation of marijuana at the University of Mississippi. And that's the single source for what they call legitimate medical research. It's really tightly controlled for the cultivation of strains, particularly for research purposes. And for a long time, many of these studies that were allowed to go through were negative studies proving the harmful effects. In order for a researcher to study medical marijuana or cannabis, they have to be approved by the FDA, demonstrate scientific validity, and get a special study license. So when we talk about why, since it's so ubiquitous in our community, it's becoming socially acceptable, this is something our patients want, this is something our states want, why isn't the DEA and the FDA jumping at the chance? Well, what are they actually looking for? They're looking for sufficient safety studies, which is difficult to have if something's federally illegal and difficult to study. They want the drug's chemistry to be known and reproducible, but you're dealing with a botanical, and depending on how it's grown, where it's grown, who's handling it, it's going to be a little bit difficult to always reproduce the chemistry. They want to make sure there's adequate and well-controlled studies proving its efficacy again, which is difficult because we don't have that scientific base, although we're building it. And they want to make sure that that scientific evidence is widely available within the US. So they go through something called a factor 8 analysis, where they're wanting also to know what's the actual and potential for abuse. They want to understand the pharmacology, the current scientific knowledge, the history, the scope and duration, what's going to be the public health risk, what's going to be the psychological dependence, and is it an immediate precursor to a controlled substance. So although it seems as though they're dragging their feet, but there's a lot of things going through their minds when they're thinking about how do we say that this is okay. So what does the Georgia law say? Well, the Georgia law did not make medical cannabis legal. What it did is it decriminalized it, and it decriminalized it for patients who have certain medical conditions, and they can possess 20 ounces, up to 20 ounces of low THC oil, which is 5% THC by dry weight, for these limited and improved conditions. The issuance of medical cannabis cards are done by the Department of Public Health following physician certification. They have to be Georgia residents. There is still no change in laws on buying, selling, or transporting marijuana or cannabis across state lines. You have to actually have a bona fide, this is actually written in the law. I love reading the law because it says bona fide doctor-patient relationship, although it doesn't really define that. And physicians cannot prescribe. All we can do is certify eligibility because it remains federally illegal. So what are some of the current conditions covered under the Georgia law? But I pointed out the ones that I think are going to be most relevant to our patients with cancer. Again, cancer, when the diagnosis is in stage or treatment produces related wasting, illness, or recalcitrant nausea, vomiting. Notice there that it does not say cancer pain. It doesn't say cancer fatigue. It doesn't say cancer sleep. It certifies when patients are really not able to use traditional pharmacology. For mitochondrial disease, sickle cell when it's considered severe or in stage, peripheral neuropathy when it's severe or in stage, and tractable pain and post-traumatic stress disorder. So oftentimes when we are certifying patients in our clinic, even though they have cancer, we are looking at some of these other criteria. So I think it's also important to kind of understand, why this is attractive, why we're studying this, and what's happening in our bodies. So we have something called the endocannabinoid system, and that system regulates a lot of key functions: sleep, emotional processing, pain control, appetite. It goes kind of on and on. Basically, almost everything we should ask, what does it not regulate? And it controls those functions by modulating nerve cells signaling in the brain. So the endocannabinoid system includes neurotransmitters that bind to the cannabinoid receptors, and we'll talk about that, and our own endogenous endocannabinoid anandamide. It mimics actually the effects of THC. Receptors are distributed throughout our nervous system. It plays crucial roles in synaptic transmission and the nucleus accumbens and various regions of the brain. And so what the nucleus accumbens is, just to remind everybody, is that's going to be the neural interface between motivation and action. So it helps control eating, how we express ourselves sexually, our reward system, stress, and drug self-administrative behaviors. So this is one of my favorite slides, and I often show this to patients when they ask me. I have some patients that ask about receptors, that there are two basic cannabinoid receptors, CB1, that is distributed throughout the body, and CB receptor 2, which is distributed through on the immune cells. CB1 receptors is expressed in the brain and mostly in the peripheral tissue, mediates, if not all of those psychoactive effects. So when a patient or somebody is enjoying medical cannabis, they're really having a good time with their CB1 receptors. And as you can see, it affects the cerebellum, hippocampus. So all the things you think of: why are they stumbling? Why are they falling? Why are they having emotional lability? Why is the appetite? Why is somebody hyper sexual? Why is there suppression of nausea, vomiting? Why is there effects on perceptions of pain? All mediated through the CB1 receptors. CB2 receptors are predominantly in the peripheral and on the immune cells and hemopoietic systems. So in the brain, CB2 receptors modulate the release of chemical signals primarily engaged in immune system functions. However, when THC, or either our endogenous endocannabinoids, or we intake THC and it activates the CB2 receptors, it does not have that psychoactive effect. So what the big push is now is to try to figure out how can you get the benefits of activating the endocannabinoid system without receiving the psychoactive effects or the high. So moving on to cannabis sativa. So patients often ask me, hey, do I need THC or CBD, or what does all that mean? So I just basically explain to them that and the marijuana plant and in the hemp plant, you have two basic substances that we care about. There's a third that we'll talk about later, but the two I really want them to remember is THC and CBD. And they both belong to a class called cannabinoids. There's over 100 different cannabinoids, and then over 60 cannabinoids in the cannabis sativa. The effects of cannabinoids depends upon the plant strain, how it's grown, and THC effects are modulated by other cannabinoids. And why this is important is how a patient is going to respond, or how they think they'll respond to a strain. So we'll often have patients buy marijuana. It's the most amazing thing they ever had. They throw away their opioids. They say, Dr. Curseen, I never need to see you again. Life is amazing. Then they get that next bottle. And oh my goodness, where is my OxyContin? This doesn't work anymore. What's wrong? And it's just because I always ask, did you get the same strain? Do you know what strain you're getting? Where did you get it? Did you get it from, a dispensary? Did you get it from, a friend down the street? Did you grow it yourself? So having patients really sort of understand that is incredibly helpful. So what did each of these substances do? Well, when you think of THC, makes sense, can be sedating or anxiety inducing, but can help you relax, alter sight and smell, basically makes you feel awesome or makes you feel paranoid and terrible, makes you feel tired, but it can reduce the aggression. And the reason why a lot of our patients come to us is for that antioxidant and anti-inflammatory properties. CBD is not psychoactive. So when we say it's not psychoactive, what we mean is it doesn't make you think like you're Batman, doesn't make you high, but it can be anxiety reducing. So this is why we're thinking people are saying, hey, grandma's upset, let's go ahead and give her some CBD. And it seems to have some antipsychotic properties, which is really exciting, especially for people in long-term care and for our older populations. It has some relief from nausea and vomiting and decreased inflammation, and has a low affinity for CB1 and CBD2, and has some analgesic properties, theoretically. There's another part that sometimes patients will talk to us about. They'll, particularly my patients who are very, very knowledgeable, they care a lot about their terpenes. So terpenes are number 3. And that's that chemical compound that's in us and in plants that's responsible for the aroma and the flavor and the color of the things that we ingest. So research is suggesting that the terpene profile with the cannabinoids content produces the effects of the different strains. So that's what they're thinking. Is that well proven? No. That's our hope. So this is if you, at the Journal of Clinical Oncology, they produced this really great, very short, easy to read article, Cannabis Use in Patients with Cancer, a clinical review, which I think is incredibly helpful if you want to know more. So just to explain that there's going to be 2 plants that you're going to see patients getting their THC and their CBD from. One is the marijuana plant. That's going to have higher concentrations of THC. The other is the hemp plant. It has a lot of CBD and a little bit of THC, but don't worry, we figured out how to get it out of the hemp plant. The hemp plant is completely legal. So if your patient does not go to a Georgia dispensary and they said they bought medical marijuana, particularly at a gas station, they are not getting marijuana. What they're getting is THC extracted from the hemp plant. And we'll talk a little bit why that is starting to worry us. So what is the evidence that this might work? Because we live in a world of evidence. So preclinically, there's a growing body of evidence that suggests that cannabinoids affect multiple signaling pathways that could be important in the development of cancer. So it can be anti-proliferative, pro-apoptotic, anti-angiogenic, and anti-metastatic activity on a wide, and they showed anti-metastatic activity on a wide range of cells in animal models. And these findings have led to the development of some clinical studies to do investigations. So why is this important? Because when patients see that medical cannabis is going to help my cancer, what they often don't understand and what often doesn't get down to like the second paragraph is that these are things that are done in vivo. These are things that are done in but the way it's presented to them is that it's actually, it's helping my cancer, so it's actually done in people, and they don't realize the difference. So this slide is pretty hard to read, but this came out of the Journal of Cancers, and just to kind of show you what can happen, if you look at the top 3 studies that are clinical. One completed with dexanabinol, which showed progression to free survival in solid tumors, per the claim. CBD showed that there was lower incidence of acute graft versus host disease after allogenic stem cell transplants. And then one that a lot of people may already be familiar with, which is Sativex and temozolomide and glioblast form increased 1-year survival with a rate of 39%. So that sounds great, right? I think it sounds pretty amazing. If I was a patient and I looked at that, I'd be like, yeah, this is definitely going to help me. And then the other studies here are listed for palliative care. So, but what's important is, and this is something that your patients are not going to do, they're not going to really read the study, and the people who are selling the medical cannabis aren't actually really going to talk to them about the details of the study. So the study looking at nabiximols. Well, preclinical studies suggested that cannabinoids may have anti-tumor effects. So what they did was they had a part 1, which was open label, and a part 2, which is a randomized double-blinded placebo-controlled trial. But in part 1, which was open label, they had 6 patients. In part 2, they had 12 patients. So nabiximols with compared to placebo. And they used up to 12 sprays of nabiximol or placebo for approximately 12 months, and they monitored for safety, efficacy, and if there was going to be any interference with the treatment. So what did they find? They found, well, just like we expect, they had some adverse events with some dizziness, fatigue, nausea, headaches, and these are things that we see. At 6 months, 33% of both the nabiximol and placebo groups were progression-free. At the 1-year survival rate, 83% in the nabiximol group versus 44% in the placebo group. And then there was no significant effects on their traditional therapy. So the conclusion that was written is nabiximols were safe and well tolerated with no identified drug interactions. That was the conclusion. If you read in the study, but if you went to the discussion, what they said at the very, very end is that survival differences warranted further study in a larger randomized controlled trial because it wasn't powered. And the authors noted that you should view these findings with caution. That did not make the front page of USA Today. The next trial that was listed in this paper, which is peer-reviewed, was a phase 1 study of dexanabinol in patients with advanced solid tumors. So this is the reason why I just have the clinicaltrialid.gov and the study goals, because the study's closed. It hasn't been published yet. So possibly the authors know something that it worked, but since 2017, there has been crickets. However, if you look at that paper in that beautiful column, 1-year progression-free survival. I'm giving medical marijuana to everyone. Third study, cannabidiol for prevention of graft versus host disease after allogenic cell transplant. So a phase 2 trial with 48 adults. They had their GVHD prophylaxis with cyclosporin, methotrexate, and low-dose anti-T cell globulin. CBD treatments were given 300 milligrams a day for 7 days before transplantation, all the way till day 30. So looking at the, 79% of the patients have acute leukemia, 73% of patients have myeloablative conditions. The results, well, there were no grade 3/4 toxicities attributed to the CBD, so that was great. GVHD, there's no acute GVHD when you consume the CBD, so that's awesome. There's a cumulative incidence of acute GVHD, grade 2 through 5, by day 100, 12% grade, but 3 through 4, and and compared to historical controls, the hazard ratio for acute GVHD with CBD was 0.3. There was no relapse mortality at 100 days, and moderate to severe chronic GVHD at 12 months, 20% at 18 months, 20% at 12 months, and 33% at 18 months. So the conclusion here is that CBD with standard GVHD prophylaxis is safe and effective at reducing acute GVHD incidence. And they did say, though, they recommend a randomized blinded controlled study. However, if you look through the limitations of the study, just to sort of think about this a little bit, one of the things that they didn't do in this study is they didn't actually control for whether or not the patients were taking it. They didn't control for how the patients were taking it. It wasn't observed. So they also noted that, again, that they needed to do randomized double-blinded controlled trials. So the statement was, and this is the tagline, that CBD helps GVHD, but actually CBD possibly might help GVHD. So, and this is one that I think we may have heard of as well, is the impact of cannabis use on immunotherapy efficacy. So we've been in our supportive care clinic, we're registering people like all the time, every day, and this came out and we were like, oh no, what are we doing? Maybe we're doing something wrong. So this study assessed the interaction between cannabis use and immunotherapy, focusing on response rate, progression-free survival, and overall survival. So the results, again, cannabis use significantly reduced response rates to immunotherapy, 37.5%, and nivolumab alone versus 15.9% in the nivolumab cannabis group. However, there was no significant impact of cannabis on progression free survival or overall survival. And cannabis composition didn't seem to influence the response state, the response rate. So if you just read the tagline, everybody that was on immunotherapy, we should just pull them off of medical cannabis and not even have a conversation. But that was the only thing that was said. So when you actually went back and read the study, it was more nuanced. It was more nuanced than that. And then they said retrospective data suggests caution for cannabis users starting it. So when we think about if we have patients who are not, we maybe want the benefits of medical cannabinoids, but we don't want them using, either buying the plant or going to the dispensaries, or it's cost prohibitive or financially toxic, then sometimes we will try to use the medically approved medications. So dronabinol, so what we said was in the beginning that it's approved for AIDS-related anorexia, cachexia, and chemotherapy-induced nausea and vomiting. However, there is some evidence that, and it's moderate evidence, that it may be effective for chronic pain. I have a few patients that I treat with just dronabinol, and they respond to it beautifully. And it's been opioid sparing, as well as moderate evidence for Tourette. For CBD, has high evidence for seizures, and that's why the medication is approved for children with seizures, and moderate evidence for Parkinson's disease. So we often will get patients referred to our clinic with Parkinson's disease to consider starting this. And for nabiximols, moderate evidence for chronic pain, spasticity, and substance misuse disorder, and we'll discuss a little bit why that might be. In this particular study, which was a systematic review, they They did comment, though, that there were serious adverse events, which were reported about 4.5% with CBD trials. So that was kind of the dropout rate for serious adverse events. Serious adverse events were tachycardia, people passing out, developing psychosis. NAB alone was about 5.4 and 6.3%. And when low acuity side effects, the numbers were a little bit higher for the dropout rate. But overall, patients tried to stay with us. So now that we've gone through that and some of the data, so what do we do with our patients? Because that's the real thing. Because do your patients care about data? No, absolutely not. They don't care anything about this. So how are we going to manage our patients, because we know that they're going to use this? So it's really important to understand, what is it that your patients believe? Believe that the medical cannabis may be a treatment for my cancer. Belief that it has evidence that it cures cancer. Belief that it has little to no side effects. Belief that it will manage pain, improve quality of life, and belief that it's non-addictive. And we'll get back to, hopefully I stay on time, and we'll get back to that word belief, because that's going to be really, really important. So this is a study that came out of our clinic, led by Dr. Ali John Sarabi, the perception of medical cannabis and ambulatory palliative care clinic. And there was a survey given, and what the survey was about patients' cannabis use, concurrent opioid and controlled medication use, and for the perceptions of cannabis benefit and harm. We were able to recruit about 101 patients. Patients were using cannabis every which way they can. They were ingesting it, they were vaping it, they were smoking it. They did, 96% of patients felt like it helped with their pain and had minimal side effects. Some felt drowsy. Others who use it heavily and would sometimes experience withdrawal symptoms, and about 14% were worried that they may be addicted. However, 59% of cancer patients believed cannabis was important for cancer cure. Now, we know when we get the survey and people are willing to fill the survey out and they're already using that, they're biased towards that. But I think the 59% believing that cannabis was important for cancer cure, because when your patients come to you, do they say, yes, I'm going to use cannabis to cure my cancer? Do they tell you that? Sometimes. But mostly they tell people like me and Anna that. So the conclusion, patients with serious illness view cannabis as beneficial for pain and symptom control with curative intent and having very little harm. So if patients are believing that, what is it, other things that they need to know? Well, they need to know the risk and benefit. They need to know how it works. What's the ratio of THC to CBD? Why does it matter? What should I expect from it? What are the side effects? Which should I use? Where should I get it? And I left off here some of the social determinants of health. How much it's going to cost me? What's the financial toxicity? What are the legal implications, particularly for patients who are justice involved? So I usually try to educate patients on the strains, because the strains have a lot to do with how they experience the medical cannabis. So there are probably more, but there are three that you want to kind of burn into your brain. Sativa strains usually have higher THC content and lower CBD content. Indica strains tend to have lower THC content and somewhat higher CBD content. And hybrid is going to be a mixture of both. So to remember that, sativa is stimulating, indica puts you in the couch. So I tell patients that. They're like, yeah, I got the one that puts me in the couch. Yeah. So again, uplifting. So if they say, I used my medical cannabis and now I wrote the great American novel and I painted my house and everything's awesome, and they have a sense of well-being and the headache's gone, the nausea's gone, and they're able to engage. They got a sativa kind. If the anxiety's gone, they're feeling like the aches and pains are better, they're sleeping better, they're able to self-relegate a little more, they're eating pretty good, then they're probably using an indica strain. And these are all some of the positive effects. So when a person goes to a dispensary, if they're having fatigue or depression, they may use a sativa strain during the day, while somebody who wants to alleviate pain and insomnia may choose an indica strain at night. Because I actually had a patient call me from a dispensary angry saying they're trying to upcharge me. I'm like, what are you talking about? They're trying to sell me two things. I'm like, no, you need two things. And so having them understand that oftentimes when they're going to buy, depending on what's going on with them, they may be offered one or they may be offered two because they do two different things, and that's completely normal. High CBD strains are often preferred by patients who are treating seizures, patients who are already anxious. A lot of my patients are already fatigued and have pain, and they are really worried about having the psychoactive effect. So these are a lot of our working patients, a lot of patients with younger children, and people who feel like they really need to stay in control. There is another one that we don't talk a lot about, but if anybody talks to you about THC diamonds, this is what they mean. They mean THC little a. And what's attractive about THC little a, again, it's not really psychoactive. It's actually found in the raw plant and like cannabis plants. And as the plant dries, the THC little a loses the A and converts to THC. But what it's being marketed to are patients with neurodegenerative disorders, patients with prostate cancer, again, used a cellular study, muscle spasms, pain, and insomnia. It actually online is listed as the THC super champ. So it may be an alternative. So if you have a patient coming back and maybe they're coming back from a different state and they have that, that is what it's for. And that one's actually not, that's your non-psychoactive THC, THC little a. So when you're actually using it, again, Georgia has only approved low THC oil, but for our patients who are using it and by inhalation, what they might expect to receive is rapid relief of pain and anxiety. So this is, if your patient's getting chemo and they're puking and they go to the bathroom and they come back in, they're fine. That's probably a vape pen and inhalation onset of action like 15 minutes. Oral of sublingual has extended durations, but patients like that because, it actually lasts a little bit longer if you're having lots of anxiety, if you want to try to sleep. Again, oral cannabis tastes terrible. No matter what they flavor it with, it just tastes terrible. And then topical, which a lot of my older patients are, like rubbing their body down, localized pain relief, secondary to the potential anti-inflammatory properties. So we'll have people use it in joint pain. We will have people use it in wounds. So some of the other pharmacokinetics, which are, I think, really, really important, is when they ingest cannabis. It's very irregular, and the peak effect can be somewhere between 1 and 2 hours. So if you have a patient that says, oh, I'm going to try this, I often say, what are you thinking about trying? I'll tell them what's appropriate, and then I'll say, that's what's appropriate, but what are you actually going to do? If they mention a brownie or a gummy, I say, take a little bit of that. Because, again, it's going to not take effect until about 60 to 120 minutes. And sometimes it can take almost up to 4 hours, depending. But once it has an effect, it is with you for about 6 to 8 hours. So if you're having a bad experience, you're going to have a bad experience for that long. What most people do is they eat a little, and they don't feel anything in 30 minutes, and they eat a little more, and then next thing you know, they ate the whole brownie, and then somebody calls the cops. So really, really important that they understand that if you have never used marijuana before, do not start with an edible. Sublingual, the peak is about 100 to 130 minutes. Increases if you have the oral spray. And it's also important for us to make sure that patients eat with it. And then inhaled cannabis is really like a like I say, it's just like a shot of Dilaudid. It's going to work in about 6 to 10 minutes. It's going to peak. It's going to be as good as it's going to be maybe in about an hour. This is why people are repeatedly smoking, going back to it. So you don't see people eating edibles all day long, but you do see people inhalation or vaping all day long. And that makes perfect sense. It's just like a PCA. Problem we currently have with vaping or vaping-induced lung disease. CDC was trying to figure out why that was happening. We thought it was from faulty vape pens, but because we don't know, we recommend that patients do not vape. So what are going to be some of the doses? So if you put somebody in the low THC registry, they're going to expect you to know what the doses are, and that really matters. The problem is, depending on the dispensary that you go to, oftentimes we're not privy to how they dose these medications, or even what dose, not medications, but dose these substances and what it actually means. But if you can get the patient to bring in their bottle orally, starting at 2.5 to 5 milligrams, this is the THC portion, because that's the part that we are most worried about. That's not a bad starting dose. So when you're thinking about patients using something in Georgia, they should be measured in drops if they're using the oil under the tongue and not using the capsule. So we'll say if 1.25 milligrams is in a drop, then that's how we sort of count it. So we tell patients, if you are getting to 20 milligrams, so that's the whole dropper and nothing's happening, abort, because probably nothing therapeutic is gonna happen. But we do need to make sure that we tell them when the effect is going to come. So there's some data around this. There's some, not a lot of great data, but it seems consistently what's coming up is somewhere between 2 to 10 milligrams of THC tends to be about the right place to have pain relief and minimize some of your side effects. Some people looking at using THC oil capsules versus other methods, 2 milligrams to sometimes up to 40 was administered, and that seemed to help have some evidence for pain relief. And the evidence suggests that medical cannabis reduces chronic or neuropathic pain and advanced cancer. However, these studies lack statistical power. And that's because, we're behind on studying it. So we need to have further placebo-controlled trials. So what I explain to patients, if their pain is better, their pain is better. It's not imaginary. It's just that we can't vouch for what this is in the same way we can vouch for your chemotherapy or your blood pressure medicine. So I just want to make sure that I put that in context. So cannabis and pain. Their cannabinoid receptors have been studied in the brain, the spinal cord, and the nerve endings throughout the body to try to understand why it's helpful. And they've been studied for anti-inflammatory effects. Animal studies show that cannabinoids may prevent some nerve problems. So is it neuroprotective? So some people are thinking maybe we should start giving it before and considering maybe starting some of it before chemotherapy. I've had patients go to dispensaries prior to starting your therapy and start this because in hopes that it would be neuroprotective. Oftentimes they will get THC little a if they're not getting it from Georgia. And then one study showed that inhaled THC on experimentally induced pain actually caused pain and then improved pain tolerance and decreased sensitivity and intensity. So this is also another warning. So just like opioids, you can become hyperalgesic. So there are going to be some patients who are going to use THC and they're going to use a whole lot of THC and then their pain is going to be way out of control. Oftentimes that just means that we have to pull back. That's not for them, or they need to use a lower dose. But so I always say, when you think of THC, sort of think about it like an opioid medication in the way that you dose it, IV, orally, and when you start to pull back from it, or what's going to be your ceiling. So the big thing is all patients, or this is what we all believe, that if I use medical cannabis, I'm going to eat better and I'm not going to be nauseated. Yes. Well, there's only 3 small clinical trials. One that said, yeah, it's going to help. The other one said, it might help, but we're not sure. And another one said, I don't know. So this is where we are with the studies. So when a patient is not helped by it, I always let them know that there are studies that show that it may not be helpful. So just cannabis has side effects. Well, everything has side effects. You know, I tell patients, if it is not food or water, whether it's produced by Purdue or Big Pharma or your grandma mixed it out back, it is a medication. We have to treat it like that. So it can cause a little bit of tachycardia, a little bit of hypotension. So you need to let people know that you're not becoming septic. You just use a little marijuana. Relaxation, sedation, and apathy. So why this is a heart problem, particularly our patients who have neurodegenerative disorders, that they rely on, you know, the rigidity in order to walk when they become really lax. Sometimes our Parkinson's patients are making the decision, either I walk or I sit in a wheelchair. The apathy is really hard, that disassociation, that's hard for families when the person's just zoned out. Bloodshot eyes. This is fairly new, increased risk of heart failure and MI, myocardial infarction. Again, small studies, but it was just presented at the American Heart Association's big meeting. Slow digestion. So patients are like, I'm not going to take my opioids. I'm just going to use medical marijuana. And I'm like, you still have to take your Miralax. They're like, no. So I said, if it stops your nausea and vomiting, what it's doing, I said, hey, it's stopping the motion in the ocean. And so that's great, but you still may need a little bit of help. Patients with gastroparesis, I'm very careful, and I really talk to them about this. Again, depression, hallucinations, and paranoia. Psychosis can happen. We particularly worry about it in older people. It doesn't happen regularly, just with THC. If they have been using it a lot, if they stop it abruptly, just like anything else, they'll be irritable, sleep disturbance, have hot flashes, and some abdominal pain. And there's something called cannabinoid hyperemesis syndrome, which I think is really important for oncology to know about, is because this can mimic an effect of chemotherapy. Like you might stop a drug, and I always make sure that I ask patients when they have uncontrolled nausea, how much cannabis are you using? Because if you're using too much, that's the trigger for that. And how you treat it is you just stop using it, and then if they need to go back to it at a lower rate. So it's always really good to know. Medical cannabis and addiction. So yes, so there's a study, and this is work being done at Mount Sinai, and the study showed positive medical cannabis enrollment, and they were looking at opioid prescription cessation, reduction, and improved quality of life. The preclinical animal models that they've been studied at Mount Sinai are starting to demonstrate that patients who receive CBD have less cravings, less desire to use heroin. So it seems like when people ask, is THC a gateway drug? Is marijuana a gateway drug? Well, yes, and possibly no. THC, however, enhances the opioid reward, self-administration, and may potentiate addiction. So for some patients, when they're really struggling to come off of opiates, they will say, I want to come off my opiate, and they'll use THC. If they're going to use THC, I say, well, you probably need to use a product that's high in CBD. That will be more helpful. And studies suggest that 9% of people who use marijuana will become dependent upon it, rising to about 17% if they are adolescents. So real pro tip, if you know that your patient is using a lot of marijuana and they go into the hospital, even though the law protects the hospitals from it, they prefer them not to use it, go ahead and start them on dronabinol, 10 milligrams TID. If they're using a lot, you can go ahead and start at QID. It will make everything better. Because withdrawal from cannabis in the hospital when you're sick looks like low-grade sepsis. And they're really frustrated. The other thing we have to be careful of are the drug interactions. So just things to know that if you have people on anticoagulation, particularly Coumadin, and we don't have a lot of those patients, but we do have some, that it could end up raising their INRs. It will also slow down the metabolism of your nonsteroidal anti-inflammatories. So instead of putting somebody on Q, like Celebrex twice a day or Q8 for ibuprofen, you may want to do that once and then really monitor for side effects. It will not cause respiratory depression, but if you give it with a benzo opiate and some Phenergan and a Benadryl, yeah, they're going to stop breathing because it's going to cause them not to be able to compensate because they get really sleepy and fatigued. It actually potentiates the effects of both of those. Diabetic medications can it can lower actually your blood sugars. And so they're looking at it as a treatment, but for patients who are on older oral hypoglycemics, they just need to know. Antihypertensives can potentiate some of that and it can have higher concentrations of some of your macrolides, your calcium channel blockers, your statins, SSRIs, antihistamines, benzos, and antiretroviral therapies. It can interfere with anti-rejection medications. So for patients who have to be on anti-rejection medications, this is a big deal. So we will usually ask if it's okay before we place somebody on the registry, particularly for our solid organs. And again, sedatives and certain anticonvulsants, it can increase. So it's just important to be aware, and they're discovering new interactions all the time. One thing that is really important to buyer beware, this is very, very important. If your patient is not getting THC from a dispensary and they're just getting it out amongst the people or from that shop down the street, they're probably getting either Delta 8 or they may be getting Delta 11. The problem with Delta 8, it's very similar to the structure of THC, but to leach all of that THC out of the hemp plant, people use a lot of stuff, and sometimes they don't use great stuff. So few people have died. Some kids, because they can get endless supplies of it, have become addicted and have died. And there are all of these warnings. And Georgia courts ruled that it's legal. So there's no way to stop it. So anytime a patient tells me that they're using Delta 8, I caution them not to, because we don't have as many eyes on it. So again, the problem isn't with the Delta 8, it's the person who is making the Delta 8. And Delta 8 comes from the hemp plant. Delta 11, we don't know as much about, and it can come from the hemp or the cannabis. So let me make sure I still have time, I'm going on time. So what are some of the communication challenges? When we're talking about medical cannabis, you've got to understand what is the conversation you are actually having. When I say this, so a patient requests that you prescribe medical marijuana. So sometimes people go, oh, well, no, you just go to Palliative Care, you see Kim about that. or no, you know that doesn't work. Let me show you a study and a slide of how the study was flawed. What I've learned over time is I start to ask them questions. So I want to know, how do you hope it's going to help you? What are you hoping for? How did you become interested? Because what I'm trying to determine, am I having a cognitive conversation or am I having an emotional conversation? Because if I'm having a cognitive conversation, they'll just say, I saw it online and said it would help with cancer. Can you explain it to me? My family's driving me nuts. Let me just get a card so I can get them out of the hair. Or I'm really tired of taking these pills. I was hoping to have a one-stop shop. Cognitive question. We can talk about science and what is and what isn't and what we think. But the emotional conversation, when I ask, if they started with, I believe it's natural medicines are better. I believe it's going to cure and help my cancer. I don't want to have more chemicals in my body. I feel it's going to make me better. I'm dying. I have to do everything that should be saved to save myself. So the gateway question sometimes that your patients are posing to you about prognosis, about their fears, sometimes just come from a request for medical cannabis. Because if you go back to the study that Dr. Zarabi did, 59% thought it was going to cure. So when interacting with patients, asking the why is incredibly important, can lead to some other conversations. And it's important to remember that when you are questioning, if you re-question somebody's beliefs, it's like questioning their faith. And when somebody has faith, it doesn't require proof. So that's another, if you meet that faith-based question with a cognitive answer, you will be disaligned with your patient. and you're going to say, well, is it going to be me or the medical cannabis? If you look on YouTube, there are over 300 million videos explaining why this is a good thing. You can't guarantee they're going to go with you. And that's a lot of over 1 million Google references that cancer may be a cure. So that is what you are competing with. And now you're also competing with industry and people who are very well intentioned, but sometimes pose it to patients like this is going to help and this is the cure all, because they also believe and they're true believers as well. So really, so it can almost be like a religious fervor. So being able to respect that value system and making space for it is going to be really, really important, because we want to make sure that we don't lose these connections with our patients. So what are some of the things I say? Because when they say like, yes, it's going to cure my cancer. I know you don't believe me, doctor, but you don't have to believe me. And science doesn't know everything. And I say, well, I know this is what you're hoping for, and I wish the best for you, and I'll be here to support you, because they're going to do it. And I have to choose. I'm going to choose the patient, and I'm going to manage you within the confines and the values that you're asking me to. I'm hopeful this treatment will help you. If it does not help, as we hope, have you thought about the next course of action? And is it okay if we discuss this? So I just ask, because what I'm trying to do is take the idea of medical cannabis as this thing, as this sort of spiritual, ethereal thing, and I'm trying to bring it down to something that is, on earth and more tangible, physical, like your chemotherapy or immunotherapy. The reason why is because when it doesn't work, you know what patients say? I failed medical cannabis. Just like they said, I failed chemo, as though it was their fault. So they're already demoralized, and self-esteem is terrible, and bad things are happening. And now they feel like their last best hope, they failed that too. So my hope for this treatment is that it will help you feel better, have better quality of life. If your cancer improves, because that is a blessing and that is wonderful. But I want to be honest, I'm not able to tell you for sure, so I don't lie and I don't skirt around it. And I explain that we don't have the evidence, but we're going to watch and work together. And as we kind of talked about, and when patients are really angry and frustrated and feel like they have failed, it's really important in that moment to stay in that conversation and connect it and remind them that, no, you didn't fail. You didn't fail, it just wasn't for you. That's really important not to miss those opportunities, because they're looking for that from you, that validation. So in summary, it's really important that patients are counseled and educated, not just on the potential benefits, which we're awesome at, but also the side effects, so they know why they fell, or they know, why they're not going to the bathroom. Patients should have counseling and informed consent, because the other things you need to talk to them about is driving. If they get stopped, it's a DUI. If they get screened, it doesn't matter. Even if they have a card, you are relying on the justice system. My husband's a judge. He says, babe, we've already said that we're not going to do anything at our national meeting, except for that guy. I'm like, I said, it's just that guy. He said, yeah, don't use it, in that county. Studies are not strong enough in the United States, secondary to legal restrictions. So a lot of the studies you see are coming out of Israel, out of Canada. They do great science in other countries, but it's hard. We will hopefully see more coming out stateside. Patients should be medically supervised. You have to know it's not a medication, it's not a treatment, but you got to know if they're on it, because it can definitely affect, particularly when they're in the inpatient, how you manage them, because they can get a lot of unnecessary testing and have a really hard time. And asking if they use medical cannabis should just be part of the assessment. So I'm so sorry, I think I ran right at time, but I really appreciate your time and taking the time to hear about something I really care about.
Thank you so much, Dr. Curseen. If you have any questions for those participating virtually, please use the Q&A feature located at the bottom of your screen. And while we wait on questions, I would like to remind everyone that next week we have Dr. Heath Skinner from the University of Pittsburgh presenting on heart and response to DNA-targeted therapy. To view all upcoming Winship Ground Round lectures, please visit the Ground Rounds page on the Winship Cancer Center or the Winship calendar. I don't know if there are questions in the room for Dr. Curseen. Okay. Read it out.
Yeah.
So we have one already online, says great talk, learned a lot. Can you talk about the signaling pathway downstream of the cannabinoid receptors and how other drugs might interfere with those signaling pathways?
Dr. Waller, I really wish I could, but I don't think I could give you a great answer, but I can definitely research it and get back to you. Dr. Lawson?
Again, a great talk. This is an emotional issue for caregivers as much as it is for patients. I know many of us. What
No, I don't think they all need to go to me because a lot of these skills are just sort of picking up on what they're asking for. So, you know, what people really want is not always to have their way, but they want to know that you respect their way and that you're interested in their value system and that you are open to their value system. So what I explain to people is that anything that's not going to hurt you, either physically or financially, because that's a huge thing, is okay, we can support. Anything that's helpful, I'm for. When you see me object, it's going to be because it's harmful. And the other part is if you have being able to talk with them about it, being open, being when you don't know the answer, just say, you know what, I don't know, I'm not the expert in this. And when my patients go to the dispensaries, why I like for them to go to these dispensaries is because I said, you need to ask some questions. We don't get training in this in medical school. Everything I learned was because Georgia made a new law, and I figured you guys were going to send all your marijuana patients to me, so I probably needed to know something about it. That is probably not great that the experts that you guys look to were just kind of self-taught. So relying on the dispensaries and the pharmacists that Georgia has approved to kind of walk you through and really give really good advice. But I don't think we should shy away from it, and we should definitely ask it, and they're going to do it. So, and if it's, like I said, if it's you or the cannabis, more often than not, it's going to be the cannabis.
Thank you very much for your presentation. I think we get lots of good clinical pearls from it. I'm a clinical pharmacist, and interaction-wise, I think there's over 390 or close to 400 interactions. But
yeah,
about 27 of them are pretty significant, like you mentioned, like tacrolimus or warfarin, Coumadin. What do you think, particularly like in the area of statins, where so many people use them? Why are we not seeing clinically relevant drug interactions when there's so many potential ones with the CYP-4 system?
Well, I think it kind of goes back to the issue with medical cannabis. So if I give you a rose, what does it actually mean to you? How many variety of roses are there? And then within that variety, so if you're dealing with a chemical that you made, you know what the ingredients are. It doesn't matter if it's summertime at the lab, the lisinopril is going to come out different. It's not. But if you have to have similar conditions and you have to be able to reproduce it. And I think part of the issue is that we don't know. The other thing is that, as I was learning as researching for this talk, a lot of things that we believe about cannabis has happened in animals and in labs and cells. And as you know, if everything that worked in animals and cells worked, then none of us would be here. They don't. Something happens on the way to getting to us. So I think that's the part we don't understand. So we did this backwards. We said, go ahead and do it. And now we're scrambling to do the research. And that's why we're finding each day, oh no, this could affect, this could affect, this could affect. But you know cannabis might affect, but you don't know if this cannabis is effective because it may have a different combination of cannabidiols, THC, and also terpenes.
All right. Thank you very much, Dr. Curseen.
Oh, adverse side effects, sativa strains and high THC brands. So Rick Simpson oil and whole cannabis extract, Dr. Nuka. If they want to use an RSO or a whole cannabis extract, I usually say no because it's very sedating. They feel really, really terrible, and they're more likely to have adverse side effects. Yeah.
I was, small medical school, I think about, operating. Fellowship training.